Good. Yay. Hello, everyone. We are going to start this webinar. Okay, we have everyone coming on. We are absolutely delighted to have you here today. We're going to have a webinar on TAVR, that's Transcatheter Aortic Valve Replacement. What's new? And so we're really excited to bring this to you today. I'm Jody Smith, your program director. We also have Mandy Sandcooler, your field services and communications director, and I will introduce our guest speaker in just a minute. Things to know while you're listening to this webinar. First of all, you are in listen-only mode, so you're not going to be able to speak during this webinar. This is a listen-only mode, but we do want your participation, so we want you to make sure that you type questions in the box called Q&A. Now, a lot of times people feel like they want to type questions in the chat box, and that is, you're welcome to chat in the chat box, but know that sometimes that can be a tiny bit distracting. So type questions in the Q&A box. You'll see it at the bottom of your screen labeled Q&A, and we will figure out how to answer them either by writing in the answer or Dr. King will answer out loud. I want you to know that although it may be frustrating but we cannot answer any questions about your specific condition or treatment. This is because no one on this webinar is your treating physician, or if they are, if Dr. King, you may be someone's treating physician, but you still can't answer on the webinar. So we cannot answer any questions of that nature. This webinar is also being recorded and will be available on the Mended Hearts Inc. website at www.mendedhearts.org and our YouTube channel as well. And we would like to do a big shout out to Edwards Life Sciences. This is an educational grant. They actually fund our TAVR visiting program in part, and they are a wonderful partner to us because without their support of the TAVR visiting program, we would not be able to provide the peer support and education that we do. So today I have the pleasure of introducing Dr. Eric King, and he's going to introduce himself further, but he is going to talk to you today about what's new in TAVR, and I'll turn it over to you, Dr. King.
Excellent, thank you. So let me make sure I can share my screen here. And how's that? Can everybody see that?
Yes, we can.
Okay. And so just a little about me. I grew up in Alaska, near the Kenai River, so Kenai, Soldotna, kind of backwoods Alaska, and then did my undergraduate school at University of Oregon, and then medical school, postgraduate at University of Idaho, and medical school in Kansas City. And then I did my my cardiology training at Michigan State University, and my interventional and structural heart training there as well. It was at a time right around when TAVI, or TAVR, the Transcatheter Aortic Valve Replacement, was just initially being started in the United States. So I was part of those kind of initial patients that were being or having the treatment around that kind of time frame of 2011 and 2012. And then really wanted to get back to the mountains and the ocean. And so when I finished training, I was looking for work and ended up here in Bellingham, Washington, in Northwest Washington, right near the border of Canada. Vancouver, Canada is right next door. And was hired here to start a structural heart program, including transcatheter aortic valve implant, PFO closures, mitral clips, and such. So we started our program here in 2015 and have been up and running since. And so aortic valve stenosis and transcatheter aortic valve therapies are something that I've been doing since I started. So that's a little about me. Aortic valve stenosis is what we're talking about today. And as we talk about aortic valve stenosis, I think there's kind of a few things I wanted to touch on just kind of quickly as we get into the meat of the matter. And I think it's important to understand how the heart and the cardiovascular system work and how that relates to aortic valve stenosis. What is it and why does it matter? And then after that, we'll talk about the treatment options. So when we try to understand the heart and cardiovascular system, it's a very simple system. The heart and the arteries and the veins create this delivery system and this for the body. So the heart essentially functions as a pump. The veins and the arteries function as pipes. So the veins take blood back to the heart after the body's used that stuff in the blood, so oxygen and nutrients and stuff. And as it comes back to the heart, the right side of the heart then pumps it into the lungs, so it gets oxygen, and then it comes back to the left side of the heart, where it is then pumped out of the heart into the aorta, which is the largest artery in the body. And then every other artery comes off of that aorta, and it is delivered to the body via the arteries. So the heart's just a pump, and the arteries and veins are pipes. And that's important because when we talk about aortic valve stenosis, it's important to understand how the heart works, because when blood comes back to the heart, it comes to this right upper chamber. And the pressure in our veins and in this right upper chamber is about 0. So the pressure is very, very low. And the heart then takes that really low pressure and it generates a blood pressure. So that's what the heart does. It generates a blood pressure and it circulates oxygen and nutrients. And so each chamber, there's 1, 2, 3, 4 chambers in the heart. Each chamber has a valve associated with it, and each chamber and valve is a little pump. So the valve is a one-way valve. As the chamber squeezes blood, it squeezes it through the one-way valve, which opens and then allows blood to go into the next chamber. And then that valve closes, and then the next chamber squeezes and pushes blood through the next valve. And so as that happens, the pressure gets higher as it goes through each valve. So it goes from the right upper chamber after the veins take blood back to the heart, then to the right lower chamber, which we call a ventricle. And then the right ventricle pushes it into the lungs where it gets oxygen. Then it comes back to the left upper chamber. Again, the pressure is a little bit higher. And the left upper chamber squeezes it through the mitral valve into the left ventricle, or the last chamber of the heart. And the highest pressure in the heart is in this left ventricle. And this is important because as you go through each chamber and each valve, the pressure gets higher, such that the valve and the chamber that has the most pressure is the aortic valve. And when we talk about that aortic valve and this chamber, that impacts the pressure there impacts its wear and tear and its aging. So when the last chamber squeezes blood through the aortic valve into the aorta, and then blood goes to all of the other arteries, the arteries that take blood to the heart, the fingers, the brain, the kidneys. Okay, so every other artery comes off the aorta. And again, the aortic valve is the last valve before blood exits the heart. Okay, and all of these valves open and close. If your heart rate's 60 beats per minute, each of these valves opens once every second. So 1 time a second or 60 times a minute. That's a very low, that's kind of a lower heart rate. So at least 60 beats per minute. And all of these valves with time will wear out. They're all very thin valves. They're tissue. They're not made out of steel or iron like your engine or your car. And they're very thin. They're a little bit thicker than a piece of construction paper. The aortic valve, so again, this last valve, when blood exits the heart, has 1, 2, 3 leaflets that should open almost all the way to allow blood to exit into the aorta, and then close all the way so that blood doesn't come backwards. Okay, so it opens and closes as the heart squeezes and allows blood to go forward. So that's how the heart works, and that's how the aortic valve works. Okay, now what is aortic valve stenosis? So aortic valve stenosis is just difficulty of this aortic valve opening. Okay, so again, it should open all the way to allow blood to exit this main pumping chamber into the aorta. But as it becomes more and more dysfunctional, it doesn't open as much. So the opening isn't as big, and it becomes more difficult for the main pumping chamber, that ventricle, to push blood through that valve, putting a lot of strain and stress on the heart. Okay, and that's aortic valve stenosis. So what causes aortic valve stenosis? The major component, the major thing that causes aortic valve stenosis, and what we see most of the time, is just generalized aging of that valve, okay, related to wear and tear. The valve deals with a lot of pressure. It's a very thin valve. It deals with much higher pressure than any of the other heart valves. and it just wears out over time. There are other things that cause it to wear out more quickly. Bicuspid aortic valve, so instead of having 1, 2, 3 cusp, it has 2. So a congenital birth defect, you're born with 2 leaflets instead of 1, 2, 3 leaflets. Similarly, infections, rheumatic fever, which we don't see much here in the United States, much radiation therapy. Calcium buildup is more another kind of function of aging or wearing out of the valve. The risk factors for a valve wearing out, increasing age. The older, if we live long enough, our valve will wear out, our aortic valve will wear out. What contributes to that? High blood pressure, right? It's already dealing with a lot of pressure. The higher the pressure, the faster it's going to wear out. It's a pressure valve. And so the higher the pressure, particularly over time, over an opening billions of times over 60, 70 years, it just wears out more quickly. Elevated cholesterol, smoking, and then there is a genetic component as well. So if somebody in your family has a history of aortic valve stenosis, particularly earlier, then you can have that can be a risk factor as well. And again, so when we look at the aortic valve, again, the last valve before blood exits the heart into the aorta, it typically has 1, 2, 3 leaflets that when it opens should open all the way, and then when it closes, close all the way when it opens and closes, okay? So, and when we talk about aortic valve stenosis, there's obviously different levels of severity. The valve can be mildly stenotic. So again, mild deficiency in opening or difficulty opening, moderate difficulty with opening, or severe difficulty with opening. And the less well it opens, the less of the opening and the less blood that you're going to get through, or the harder the heart has to work to get blood through that opening. How do we evaluate that? Oftentimes it can be evaluated or picked up on a physical exam. So when a doctor listens to your heart with a stethoscope, that's one of the things he's listening for. As that valve becomes more and more narrowed, it can cause what we call a murmur. A murmur is different than aortic valve stenosis. A murmur can be associated with aortic valve stenosis, but it can be associated with other things. There can be normal heart valves that have a murmur or make a murmur sound. And then there can be really bad heart valves that don't necessarily have a bad murmur. The aortic valve stenosis murmur or sound is created by turbulence as blood is being pushed through this narrowed opening. So a murmur is just a sound that the heart makes as it squeezes blood through that valve opening, causing turbulence. The other way that we can evaluate that stenotic valve is with a transthoracic echocardiogram or an echocardiogram. Also, invasive tests like a cardiac catheterization or coronary angiogram, typically done with a catheter through the groin or through the arm, and even CT imaging. And again, we kind of talked about how it's graded. Most of us are born with a normal functioning aortic valve, but again, as it wears out, which it does for all of us, it progresses from mild to moderate and severe, and then it can actually reach a critical level. And that becomes important when we talk about treatments. And then there are some gray areas as well around this kind of diagnosis that become a little bit, I think, above what we want to talk about here. But sometimes you can have a severe valve and not need surgery, or a moderate valve and maybe need surgery. So let's see here. So, oops, sorry. So we'll kind of skip through that side, I think. So why does aortic valve stenosis matter? It matters because, again, it's a progressive disorder. If you've been told you have aortic valve stenosis, it may not get worse, but it's not going to get better. It's kind of like gray hair and wrinkles that way. The valve is not going to improve or reverse its aging process, its wearing out process. So it's something that needs to be monitored. As the valve becomes more and more significant, it can cause heart dysfunction and ultimately can cause heart failure. With heart dysfunction and heart failure, you can become sick and have need to be hospitalized. And then also there is also the possibility of needing more medical therapy, shorter lifespan, and then needing a treatment for it, such as a surgical aortic valve replacement or even a transcatheter valve replacement. When you have a diagnosis of severe symptomatic aortic valve stenosis, and that's important, severe and symptomatic, we know that there's about a 50% mortality at 2 years. Okay, so that's why we treat it. It's also one of the most common valve procedures, or one of the most common heart procedures done on patients in the United States. So the symptoms of aortic valve stenosis, once you have a diagnosis, or even if you don't and you're monitoring for symptoms, the symptoms can be very subtle. Usually the first symptoms that patients experience are not going to be, this horrible, very sick, needing to be hospitalized type symptoms. But very often it's just a shortness of breath, fatigue, decreased activity tolerance, or decreased energy or activity capacity. That's really the most common things we see. And that obviously becomes difficult because as we get older, we are not as able to do what we were a couple of years ago. We're maybe not in as good a shape as we used to be. And so the most common symptoms of aortic valve stenosis are also very similar to the most common symptoms with aging, right? Which makes sense. Again, this is a very progressive process that occurs slowly over time. As it becomes more significant and more severe, symptoms such as shortness of breath at rest, chest discomfort, feeling like you're going to pass out or passing out, or even heart failure symptoms such as not being able to breathe lying flat, short of breath just while sitting, or with very minimal activity, swelling in the legs, and maybe even the abdomen. Aortic valve stenosis, the treatments for aortic valve stenosis include medicines, surgical aortic valve replacement, and transcatheter aortic valve replacement. So when should it be treated? Aortic valve stenosis should be treated when a patient develops, I'm just going to go back this slide here, severe aortic valve stenosis and it's causing symptoms. So if somebody has severe aortic valve stenosis but they do not have symptoms, we can still monitor that. If somebody has moderate aortic valve stenosis and they don't have symptoms, or if they do have symptoms, we should monitor them until the valve becomes severely stenotic or severely narrowed. So patients that should be treated or considered for treatment should have severe aortic valve stenosis and symptoms. And we could spend some time talking about that. When we talk about treatments, there's really, again, 3 ways to treat it, which is conservative management, which is just kind of letting nature run its course, letting and we will see this in our very elderly patients, patients in their 90s and maybe even close to 100 that really don't want to do invasive therapies, and so we just let it run its course. We talk about medical management, treating heart failure when it arises, comfort care, ensuring the patient gets to live out their life the way that they would like, however long that may be. If it's going to be treated, there's 2 different types of invasive therapies. There's surgical aortic valve replacement and transcatheter aortic valve replacement. Now you'll hear me say TAVI and SAVR. So I say SAVR for surgical aortic valve replacement because the surgeons open the heart and they cut out the old valve and sew in a new one, so they replace it. And if it's a transcatheter aortic valve implant, we just implant it inside of your heart valve. So you'll hear me say TAVI or TAVR for the less invasive one. So again, surgical aortic valve replacement is where the surgeon opens the chest, the skin, opens the bone, spreads it apart, and then opens the heart. They then cut out the old valve, the damaged valve, the aged valve, and then they sew in a new heart valve, and then they close everything up. With the surgical aortic valve replacements, again, this is an open heart surgery that's done with a heart-lung bypass machine. Patients will get sternal wires to close up the chest, and this is a procedure in which patients will either get a metallic valve or a bioprosthetic valve. Here's a picture of a metallic valve. It's usually 2-leaflet valve or a bi-leaflet valve that is almost all metal. That again is after the old valve is excised, this valve is sewn in. And with this type of valve, the metallic valve, all metal valve, patients will be on lifelong anticoagulation so that this valve does not develop the clots on it. There are bioprosthetic surgical open heart valves. These are made out of both cow and heart tissue, or bovine and porcine heart tissue. And again, they kind of have a little bit of metal in them in spots, but the leaflets themselves and most of the valves are made out of, are bioprosthetic, or made out of man-made valves made out of animal heart tissue. Transcatheter aortic valve implant, again, because this is a procedure usually performed through the artery and the leg. Alternatively, it can be done in other sites as well. The valve is implanted through a catheter, so a tube that we use to get into the artery. The tube's about the size of a finger. It's about a half a centimeter in diameter, and the valve is got a metallic frame, and then 3 leaflets made out of animal heart tissue sewn or mated into this valve structure. This is the Edwards valve, and then this is the Medtronic core valve. They're a little bit different in that this is a balloon expanding valve, and the Edwards valve is a self-expanding valve. This one's delivered on a balloon, and this one's delivered on just a catheter that is then open to allow the valve to expand. And so this is just pictures. This is the Edwards valve. Okay, again, this is a metal. It has a stent frame that kind of looks like chicken wire. It has 3 leaflets. This one's made out of cow heart tissue that are sewn into that frame, and then a skirt that is kind of like a sealant. This sits right where your valve or the patient's valve is. This metallic frame and skirt push the old valve out of the way, and once it's expanded with the balloon, it is then opens and closes just like a normal heart valve should. And it's delivered through a catheter, which is just a hollow tube about, again, a half a centimeter diameter, that is put in usually through the artery in the leg. This is the other valve, the Evolut FX system. And this valve is a self-expanding valve. So it wants, when we collapse it down, it wants to spring open. It has, again, leaflets, or those little floppy things that open and close, that are made out of pig heart tissue or porcine heart tissue. And this is just a picture of the catheter. And again, this catheter is about a half a centimeter in diameter. The way that these valves are put in is they're put in with a big tube that goes usually in the groin. It can go in the carotid artery. It can go in the arteries in the arm, through the chest wall, several different places, but usually through the femoral artery. And we put a wire up that femoral artery and into the heart. And then we collapse that catheter. We actually crimp it down in a vise, and so it's very small, about the size of a finger. And then through that tube, we push it up here, and we get it positioned right inside of the patient's heart valve. And once it's inside of the patient's heart valve, we then either open it with the balloon or let it expand as we deliver the cover off the valve. And it is then placed inside of the old valve. The old valve is pushed to the side, and then we remove our delivery system, and the valve starts working automatically. The workup for a new valve is over time has kind of changed. They used to just work patients up for either a surgical aortic valve replacement or the transcatheter aortic valve implant. The workups now, we essentially, in most places, will work patients up for both of these procedures. The workup is usually a CT of kind of the chest from the neck down to about the thighs. That allows us to look at the heart, the aortic valve size, to measure the valve for sizing, to look at the aorta to determine if there's any significant plaques or abnormalities, and then also look at the femoral arteries to see if they're large enough to get the delivery system up there. If not, then we would look at alternative access in like the carotid artery, the subclavian artery. Also, we do a coronary angiogram, which is just a procedure where we go through the artery in the wrist or in the femoral artery as well, put a tiny catheter up there and look at the patient's heart arteries. Anytime we're going to consider somebody for valve replacement, we want to know what the heart arteries look like. We want to know, are they healthy? Are there blockages? do those blockages need to be treated with bypass surgery, or can they be treated with stents? If they need to be treated with bypass surgery, then we'd consider doing obviously the open heart surgery and doing the open heart valve surgery, so the SAVR, the surgical aortic valve replacement, and bypass at the same time. If there's no blockages, then patients typically can be a candidate for both the TAVI and the SAVR. Oops, sorry. After the angiogram, they're evaluated by a cardiothoracic surgeon, and all patients are reviewed by a heart team, which is just a group of most programs have interventional cardiologists, which is what I do, cardiothoracic surgeons, which they do open heart surgery, a coordinator of the team, and a staff of supporting staff of nurse practitioners, physician assistants, and nurses and such schedulers that talk about the cases, scheduling, and what would be best as far as treating the patient with either an open heart surgery or a less invasive transcatheter valve procedure. So when we talk about transcatheter valve implant, it's kind of a process. The diagnosis of aortic valve stenosis can occur at any time between somebody having very mild stenosis and no symptoms to someone being quite sick and in the hospital. So if it's not severe, if it's mild, if it's moderate, or even if it's severe and there's no symptoms, then typically we'll monitor that patient until they develop symptoms or until the valve becomes severely narrowed. We typically will get an echocardiogram at least once a year, and sometimes more frequently if necessary. As patients become more, as the valve becomes closer to being severe and/or patients have more symptoms, then we start talking about the workup and the treatment of aortic valve stenosis, including, the treatments, SAVR versus TAVI, the patient's desires and wishes regarding, treatments and therapies, and then also their candidacy, because everybody's different. And the workup for the procedure, we just talked about that, but the workup can be quite extensive. You end up needing, here we do a carotid ultrasound, we do the CT scan, we do the coronary angiogram. The coronary angiogram requires kind of a full day in the hospital. We do cognitive function testing, so and frailty testing. And then we also have conversations with patients around their procedural risk and comorbidities. So the younger and healthier we are, obviously the less risky these procedures can become. But as we become older, we become a little more frail, the body becomes more prone to injury, and there are increased risk related to procedures. So those are all things we kind of try to talk about as we approach a transcatheter valve procedure or even a surgical open heart procedure. One of the main things we really try to do is have realistic conversations with patients and families around the benefits and risk of a procedure. One of the things that is a common misconception is that how someone is feeling is directly correlated to their aortic valve stenosis. Very often, that could be a small component of it, but often what we see is that it is a small component, and that generally, if we're talking with patients that have aortic valve stenosis, most of our patients are in their 80s and maybe even their early 90s, and those patients generally have decreased energy or decreased activity capacity for a lot of reasons. Most of those being that, as we get to be 80, we just don't have the energy we used to. So when we talk about aortic valve stenosis and treating it, very common, we try to let patients know that often they may not feel like they have much more energy. They may not feel better. Some patients will. If patients do, it typically takes about a year or so before, 6 months to a year before patients really do start to notice if they feel better. Even though we fix that heart valve with a surgery valve or a transcatheter valve, the heart still has to go through changes. As that valve becomes more and more narrowed, what happens is that the heart's a muscle, and it has to push blood through that valve. And so the heart becomes more muscular, and it becomes dysfunctional. And what happens is when we replace this heart valve, that heart muscle is still thickened and dysfunctional, but the valve is now good. And so then it takes some time for that heart muscle to go back to more normal kind of thickness. When the heart's thick, it's not as flexible. The heart should do two things. It should squeeze to push blood, but should also relax to fill with blood. And so when it becomes thickened and stiff as it's pushing against a narrow heart valve, it is less flexible and doesn't work as well. So once we put a new heart valve in, it can take 6 months or even 12 months for that heart muscle to go back to more kind of normal function. And that's about the time frame we typically see patients feeling better. The workup for the procedure, generally, if we diagnose somebody with aortic valve stenosis that is severe and they have symptoms, we will see them, and the whole process usually, unless there's a reason to try to do it more quickly, takes about a month. So usually, if we see them and they get their heart valve done in about a month, and that requires getting all that testing and those follow-ups, the visits that are necessary to get the testing. To get the procedure. The procedure itself. So most of our patients before the procedure will may have to hold a couple medications. The day of the procedure, the patients will come in and they'll be NPO, or they won't have eaten or drinking anything. The procedure is it's usually a couple hours to get ready for the procedure, and then the patients go into the room, and they're usually in there for about an hour and a half. The procedure itself takes about an hour, and then after the procedure, there's about 4 hours of bed rest, and then everybody stays overnight. So there are some programs that are sending patients home the same day. We still keep everybody overnight, and patients have about 4 hours of bed rest to allow those holes that we put in the groins to heal up. We do close those and suture those up, but they still need to heal before the patient gets up and walks around. And so after that bed rest time, then patients can get up and sit in a chair and can obviously walk around a little bit as long as it's nothing strenuous. We keep everybody overnight, and then patients are usually discharged home the next day. Obviously, if there are risks with the procedure, and if something happens, then patients could stay longer. For most patients that get a transcatheter or a TAVI or TAVR, Transcatheter Aortic Valve implant, generally speaking, the risk of the procedure, the risk of major bad things, heart attack, stroke, death, emergent open heart surgery, those things that none of us want to see, major vessel damage, are usually right around 1% to 2%. There are definitely patients that can have higher risk. If you've had a stroke before, then that patient's risk will be higher. If patients have really bad peripheral arterial disease, then the risk of damage to the arteries is going to be higher. But generally speaking, it's around 1% to 2%. The most notable risk with a transcatheter valve implant or TAVI is going to be a pacemaker implant. So where we deploy this heart valve is right where the electrical system in the heart is. So the electrical system runs in between the two sides of the heart and runs right down along here. Where we put the heart valve in is right inside of the aortic valve, and it just pushes the old valve to the side. And if it pushes, when we put it in there, pushes on that electrical system, it's really just kind of tissue. And if it pushes on it and disrupts it, then the patient may need a pacemaker. They could develop heart block, slow heart rates, and need a pacemaker. The risk of that's right around 10%. It's really kind of between 5 and 15%, depending on which valve and the patient's underlying rhythm, heart rhythm at baseline, but right around 5 to 15%. If somebody gets a pacemaker, then usually that happens the next day, at least our institution, and then they'd stay one more day before they went home. After procedure discharge, patients' activity restrictions are usually no lifting more than 5 pounds for about 1 week. That's a big, the recovery is really the big difference between surgical aortic valve replacement and transcatheter aortic valve implant. The hospitalization for the transcatheter valve is usually, again, 1 to 2 days. With surgical open heart surgery, it's 3 to 7 days. And then the recovery, the restrictions, again, it's just 1 week of no exertional activities. Patients are able to walk, they're able to do stuff around the house as well as they're not lifting more than 5 pounds. There is, and then at a week, we usually will see our patients, and if they're doing great, then we usually lift those restrictions at about a week. There's often medication changes. Once we put that valve in, oftentimes blood pressure can change, and we have to change the blood pressure medications. There are some medications that are better for the heart valve, and those include some blood thinners that can help prevent clot from developing on the valve. So patients may be placed on aspirin or another medication called Plavix. And then obviously there's always testing and follow-up appointments. Oftentimes our patients will be seen at about 1 week and after the procedure, and then also again get an echocardiogram at a month to evaluate the valve in the heart, and then also seen in a month. And then it's also recommended that once somebody has a heart valve that they get an echocardiogram every year, and generally recommended that they see a doctor every year as well. Anybody that gets a new heart valve, a bioprosthetic valve, or a mechanical or metal heart valve, whether it's TAVR, surgical aortic valve replacement, or TAVI, transcatheter aortic valve implant, they should get antibiotics for specific procedures that could infect the heart valve. So invasive dental procedures and even other procedures. And most physicians will know what procedures would require antibiotics to protect that heart valve. So that's the majority of what I wanted to talk about. In relation to TAVI, there's always new technology. When this procedure was started, we did almost everybody with big surgical incisions to get down to the arteries. We opened the arteries with a surgeon, and then we closed those surgically. Everybody had an ET tube, an endotracheal tube placed, and were essentially required an anesthesiologist to help them breathe. We did a transesophageal echocardiogram during the procedure. The biggest changes that we've seen is minimizing all of that stuff to do the procedure. Most of these procedures now are done in a cath lab with minimal sedation, without having a tube for breathing in the throat, or an echocardiogram put down the esophagus to look at that valve. They're percutaneous, meaning we don't make incisions. We just push the systems in through the artery and end up with a very tiny hole that we can close with just a single suture. So the other big things that we're seeing that are changing is patients going home much sooner. Patients usually used to stay 3 to 5 days, and now they're going home the next day. And some centers, depending on how young and healthy you are, they're sending you home the same day. We're seeing new valves be developed, and the current valves being improved such that they're delivered through smaller systems. They're smaller and easier to get up. They work better. They don't leak as much. All of those things that we see with progression. So that's really, I think, the biggest changes. There are obviously, in this world of transcatheter procedures, doing procedures through a catheter, more and more procedures that are coming about to treat the mitral valve and clip valves, and also treat the tricuspid valves and work on other valves. And so that's all coming about as well. So I guess I'll end there. I know that was a ton, and I talked really quickly. So I'll see if anybody has questions, and we can spend some time answering those if you'd like.
You have a lot of questions, Dr. King. That was an excellent presentation, but we have a very well-educated membership, so they always have a lot of good questions. So I'll go ahead and start with the first one. Laura says she's in a trial with Cedars-Sinai and was told that her valve is a combination of animal and metal. Does this have to be changed in 10 years?
Yeah, so that's a great question that I didn't talk about. So for these bioprosthetic valves, which is a combination of a metal and a animal, or usually again a pig or a cow tissue valve. So again, when you say metal, this part is metal, And this part here is made out of either cow or pig heart tissue. Those bioprosthetic valves, we expect them to last 10 years, and we hope that they last about 15. And so, yeah, they wear out, right? Just like our valves do. They don't last as long as our valves do. And in about 10 or 15 years, patients may need a new heart valve. The great thing is that usually what we're able to do is just put a new heart valve inside of it, okay? So when a valve wears out, just like we put this valve inside, we'll put it inside of your valve that you have or that a patient has. When the valve that we put in here, this new transcatheter valve wears out, we can put another one inside of it very often. That's the great thing about the metallic valve. So when we talked about this metallic valve, is this valve doesn't wear out. Now, typically these metallic valves, we really don't put those in patients unless they're around the age of 50 anymore, only because it requires lifelong anticoagulation, a lifelong blood thinner. And a blood thinner at 50 is not a big deal, but once we get to our 80s and 90s, a blood thinner is a huge deal. And so most of the time, we prefer to say we're going to put a transcatheter valve in, and then knowing that if it fails or wears out, that we'll put another one inside of it down the road. Good question.
Thanks. Ed wonders if there's any movement towards using TAVR or other catheter approaches for replacing regurgent aortic valves that are not stenosed.
There are, yep. And a large trial was just finished. There's a valve that's been developed specifically for that reason, for the aortic valve. The results of that trial should be announced this year at a big cardiology conference, and we suspect that it'll be favorable. So absolutely, there's already patients that have had that done in a trial setting. It's a different valve than these valves because these valves require a junky valve, a calcified valve, to hold them in place. And that's something I didn't spend a lot of time talking about, but as that valve wears out, it becomes initially kind of calloused and thickened and stiff. It just from wear and tear. And as it becomes stiff, it becomes injured. And that injury creates calcium buildup or calcium formation. And so the valves that we treat, the stenosis valves, are very calcified and thickened and stiff. A lot of times regurgitant valves or leaky valves, those valves oftentimes aren't like that. They're not calcified, they're not thickened, they're not stiff, and so it requires a different type of valve implant to work for those valves that don't have the calcium to hold them in place, because they'll just fly off. So yeah, hopefully that answered the question.
Yeah, that makes sense. I know you can't comment on individual physical rehab for patients, but do you overall with your patients encourage physical rehab after they're released?
Absolutely. And we do, and we try to get all of our patients to get to cardiac rehab. Where we're at, it's a little tricky. We have patients that live on the San Juan Islands and maybe even up in Ketchikan, Alaska and such, but the patients locally do very good with cardiac rehab. Again, as this valve, a lot of times as the valve becomes more and more severely narrowed, patients develop symptoms very progressively, but oftentimes slowly. They don't appreciate how much it's impacted their life because it's occurred so slowly. And so when we fix this valve, we try to get their heart stronger. We try to get them exercising. And like I mentioned before, that heart valve becomes the heart muscle becomes dysfunctional as the heart valve is more and more narrowed or dysfunctional. And once we fix that heart valve, then the more active people are, the more they're exercising and doing stuff, the better the heart will do, the stronger it will be, the faster it will recover. So cardiac rehab is a perfect kind of stepping stone to improve that exercise capacity. It's initially monitored. They help you come up with programs, or help patients come up with programs that are suited to them, that they can do safely. As we get older, we all have joint aches and pains and such, that those rehab specialists are able to help you develop, or help patients develop, a program that suits them and can help them get back in shape and more active and recover better and feel better more quickly.
Thank you. How do you decide between the Edwards valve and a balloon valve for each patient?
Yeah, that's a great question. So the Edwards valve is the balloon one, right, that we have up here. The Medtronic valve is a self-expanding valve, and it becomes very complicated. I'd say that the Edwards valve is used most of the time. When you look at the literature, probably 70% of the time. But there's a lot of factors that go into it. One is how comfortable the physician is with the two valves or the two systems. They're both different. They both have nuances as far as how they're implanted. In some patients, one valve is going to be better than the other due to either the patient's their valve size, how tortuous it is as far as the iliac arteries. Sometimes the amount of calcification, also things such as pacemaker risk. The pacemaker rate is a little bit higher with the Medtronic valve. So there's a lot of variables that come into play. I'd say most centers are comfortable using both valves. I'd say most of the time, the Edwards valve is probably the primarily considered valve. But there are centers that definitely will implant more of the Medtronic valve as well. So that being said, they're both excellent. The differences between them are just very minor and overall very insignificant. And there's just kind of very nuanced subtleties between the two when you talk about advantages and disadvantages. So I think that as far as durability, they're very similar, 10 to 15 years. As far as adverse events, major adverse events, very similar, 10 to 15 years. It's just some very subtle things that would make an operator choose one over the other. Sorry, it's hard to be more specific than that. There's just so many, this very kind of technical things that would be very difficult to understand as far as why I would choose one over the other.
I think you did a great job. How different are the Edwards valves for the open heart versus TAVR, for SAVR versus TAVR?
Yeah, and the biggest difference is that when you look at the transcatheter valves, right, they have more kind of this metal stent. It's kind of like a stent. The frame is taller and longer. There's more kind of metal in there to create a structure to attach the valves to. You have to be able to collapse them and then expand them. So you can see that they're quite a bit longer. And when you look at the surgical valves, they just really kind of almost have this little wire that runs along here. There's a lot less metal, a lot less of it. It's really just more to hold that tissue in place. And so the biggest difference is, again, that with the surgical valves, they excise or they cut out the native valve. So the old aortic valve that's worn out, they cut it out and then they sew this valve in its place. So that's the biggest difference. And with the transcatheter valve, again, these two valves have a lot of surface area. They have to be able to sit in there and hang on and not move anywhere. So that's why they're kind of designed this way.
How is the size of a valve determined, the size that's going to be used?
Yeah, absolutely. So again, as far as when we start evaluating somebody for aortic valve stenosis, one of the tests that we do is a CT scan, and we do an angiogram as well, an echocardiogram. At our place here, we do carotid ultrasound, and that CT scan lets us again look at the arteries that we're going to put the valve up. It also lets us look at the aorta. Is there any significant plaque or junk in there? But it also allows us to measure the patient's valve size. So we actually go in there and measure that valve size. We get a very exact measurement, and then there's different sized valves for both for even the surgical valves, for all the valves, so that we try to get the closest fit with the patient's valve size.
Okay. For younger patients who you would think are often presumably more active, does their TAVR valve wear out sooner than an older patient who might be more sedentary? Yes,
it does. Yeah. And that's where it becomes a little bit tricky when you talk about which valve is the right valve and which treatment is the right valve. So absolutely, patients that are younger, their valves wear out more quickly.
And speaking of that, you're doing a lot more TAVRs on younger patients these days. How young can a person be to get a TAVR?
Yeah, so they can be young. I mean, there's the youngest patient we did was 38 here. And there's patients definitely younger around the country that have had TAVR valves implanted. So generally the guideline recommendations, and that's based, that's where the literature, the studies that have been done, those studies, patient analysis, registry data. So everybody that gets a valve goes into this register of data, and we're able to look at those. Helps us kind of determine what the best therapies are. But generally speaking, patients less than 65 should get a surgical aortic valve replacement, open heart surgery. Patients with a bicuspid valve should get a surgical aortic valve replacement. And then patients 65 to 80 should be considered equally for the two procedures. And patients 80 and older should be considered for the TAVR over the SAVR.
You talked about different causes and symptoms, but does diet have any effect at all on how much calcium builds up?
Not really. No.
Not really.
I mean, other than indirectly, it can, right? If we have very unhealthy diets and we therefore develop diabetes and hypertension and high cholesterol and significant obesity, those things can obviously cause the valve to wear out more quickly, right? So hypertension, high cholesterol, really, if we're overweight, that's more work for the heart and for the heart valve, and so those things. So indirectly, it can, right? If we very unhealthy, absolutely.
Are catheter procedures possible for other valves other than the aorta?
Absolutely. So we've been doing pulmonic valve procedures. That was actually present before the aortic valve, and they're being done on essentially all the valves, the tricuspid valve, the mitral valve as well. Yep. And that's a continued growing field for catheter-based procedures. Absolutely.
Okay. I don't know if you can answer this because you're not a visitor, but you see a lot of mended hearts visitors. What type of encouragement is best for this type of surgery? For both, I guess, a TAVR or an open heart. Is there anything you could pass along to our visitors who are on the call?
Encouragement. Yeah, I think I think that's tricky, right? I think the encouragement is that this procedure, whether it's a surgical or valve replacement, open heart surgery, a really big procedure, or the transcatheter valve implant, these procedures have come so far. And the transcatheter valve, even if you go back to 2011, which is when the first ones were done outside of trials in the United States, the procedure has been perfected. It's so much better than it was even then. The same thing with surgical aortic valve replacement. It's such a standard basic procedure for the heart surgeons that, generally speaking, this is something that most centers are going to do a really good job with, right? And so I guess that would be the encouragement. I think that, yeah, I guess I'll leave it at that. I think that's where mended hearts is super helpful and important, is because every patient's different, and the struggles, the difficulties, the risk, and even the benefits of a procedure like this is going to vary from individual to individual. And there'll be patients that I'll encourage to get it done, and patients that I'll discourage from getting it done, based on their age. I'll have patients that have significant dementia and are 98 years old, and their family really wants them to get them done, and they don't. And at 90, once you get to 90, this valve procedure it's not going to help you live longer, right? So that's one of the reasons why do we do a heart valve, whether it's a surgical valve or a transcatheter valve. We do it to help people live longer and or feel better, right? And so patients in their 90s, generally we can't help them live much longer. So we're looking at trying to help them feel better. And so patients like that, we may not help them feel better. And so I may discourage patients from getting the valve. So yeah, that's where mended hearts is super helpful, right? To speak to other people that have either undergone, surgical aortic valve replacement, transcatheter aortic valve implant, their experiences, how they felt before and how they felt afterwards. Because again, it's so different for everybody. Yeah.
That was great. And we've just got about 5 minutes left, so time for one more question that I'm going to kind of roll a couple of questions into one. What are the symptoms of a TAVR valve going bad? And then how many times can they be replaced?
Yeah, so the symptoms of it going bad are similar to the symptoms when the first valve went bad, right? The valve that we're born with, our native heart valve, went bad. If it wears out. So generally speaking, what will happen is the valve will just wear out over time. It'll become thickened and calcified, just like the initial valve that was a problem. And the symptoms initially are going to be shortness of breath, fatigue with exertional activities, right? So usually, again, exertional stuff. Patients that aren't doing anything, that are just sitting around, may not appreciate symptoms. But patients that are getting up and doing stuff generally will feel like their ability to do exertional activities is going to be diminished. So walking up hills, walking upstairs, lifting and moving things, that's where patients will experience it first. In most centers, again, the guideline recommendations are that we get echocardiograms annually, so yearly, to monitor these heart valves. So we generally have an idea if they're deteriorating or failing, and we may have patients come in more frequently to be monitored. One of the things with these heart valves is they can become infected, or they can develop clot on them, right? Which we call thrombus, so the thrombose. And if that were to happen, then those valves could fail rather quickly, right? If they become infected or they get clot that closes them off. The symptoms with that could present as heart failure, right? You could end up very sick in the hospital pretty quickly.
Well, thank you very much. We're almost at time, so we're going to end it there. And just on behalf of the organization, we want to thank you for such an excellent presentation. We really appreciate it.
Absolutely. My pleasure.
All right.
Hopefully I clarified some things for everybody. And yeah, absolutely. I do not mind at all.
Thank you. It was
You got a bunch of kudos in the chat box. So when you're getting thumbs up and little celebratory icons as well, and clapping hands.
Well, thanks everyone. I really appreciate it.
Well, thank you. Thanks
so
everyone
much.
for being on.
Bye.
Have a great evening. Bye, everyone.
Bye-bye.